All right, so AK is a 72-year-old female, and she presents to your pharmacy with pain in her left knee and her right thumb. The pain in her left knee started 6 months ago and is constant and aching. The pain in her right thumb started yesterday morning, and it's throbbing and sharp. Upon further investigation, you notice that her thumb is red and feels warm to touch. She has dyslipidemia, obesity, insomnia, and hypertension, which is well controlled. She's allergic to bee stings and grass pollen. She's currently taking rosuvastatin, lorazepam, and candesartan. She is a former chain smoker. She quit 5 years ago. She enjoys fine dining and eating out most evenings. She worked as an investment banker, and she retired 10 years ago. Okay? So there's a few questions related to her. Based on her presenting signs and symptoms, AK is most likely presenting with A, an acute gout attack and chronic osteoarthritis, B, a chronic gout attack and acute osteoarthritis, C, tophaceous gout and a strained knee ligament, or D, myalgia due to the rosuvastatin. What is the correct answer? Yes, good. The answer is A. Okay, so why is it A? Why is it an acute gout attack and chronic osteoarthritis? Because her knee pain it started 6 months ago, and it's constant and aching. So that's consistent with osteoarthritis pain. It would be long-term aching, sort of a lower grade severity. In terms of her gout, her right thumb, which is a classic presentation right thumb, or any thumb, fingers, and it started yesterday morning, and it's throbbing and sharp. So gout pain is severe, it's intense, it's very sharp, and it's usually acute. Okay, so that's why she has acute gout and chronic osteoarthritis. You wouldn't have a chronic gout attack, right? You have attacks. They're not chronic. And then acute osteoarthritis, no. Tophaceous gout, no. There's no indication of tophi. We haven't heard of anything, and so that can't be correct. And the myalgia due to the rosuvastatin, myalgia would be in usually like your larger muscles, like your legs, your thighs, that kind of thing. And also, she's on a very low dose of rosuvastatin, 5 milligrams, so it's unlikely that that's the cause of her pain. So the answer is A. Right. So now, you advise AK to visit her doctor for further assessment. She returns with a prescription for acetaminophen, 1 gram POQID, and allopurinol, 100 milligrams once daily. Her doctor told her that she's experiencing her first gout attack and that these medications should help. Her doctor also told her that her thumb does not show any damage on the x-ray, which she was happy to hear. Which of the following is correct? A, AK is on appropriate drug therapy and should be counseled on adjunct non-pharm measures such as weight loss. B, AK should not take allopurinol as it interacts with candesartan. Her prescription should be changed to febuxostat instead. C, AK should be switched to naproxen for pain relief, and she does not require allopurinol therapy. Or D, AK should be switched to prednisone for pain relief and does not require allopurinol therapy. So that's why I was saying I'm going to ask you a question about how to choose between therapies for gout. So what's the correct answer here? Yes, the correct answer is C. So why is it C? Well, the NSAID will help with her gout pain, which we know it was one of the 3 options you could use. You could use NSAID, colchicine, or steroids. So the NSAID will help with her gout pain. And because she may have osteoarthritis, the NSAID will also help with the osteoarthritis. Acetaminophen will not help and is not first line for osteoarthritis or gout. And she doesn't need to be on allopurinol because it's her first episode and she's not asymptomatic. We don't know if she has any evidence of radiographic damage. And the NSAID is okay because her hypertension is well controlled. So that's the reason. So it's not A because she doesn't need to be on allopurinol. It's her first attack. She's not asymptomatic. And if we go back to the gout lecture, we had like a nice summary on when to start allopurinol. She doesn't meet that criteria. It's not B because thiazide diuretics interact with allopurinol, not ARBs. and thiazides can potentiate allopurinol toxicity. And it's not D because, again, she doesn't need to be on allopurinol. Okay, so in this case, if we had to choose between an oral NSAID or a steroid, either would be reasonable because her hypertension is well controlled. We would just need to monitor her blood pressure, but that wasn't the case here because the naproxen would help with the osteoarthritis as well. Obviously, if they have osteoarthritis, they shouldn't be on steroids forever. If this was an actual case, would we contact the doctor to ask about lab results? Because the serum urate levels are above 535, we still initiate. Yeah, in this case, you would definitely want to speak to the doctor and say, okay, is there a reason why you've started allopurinol? Maybe you don't know anything. Maybe there's something you don't know about her history. Like maybe she did have an attack previously, and maybe this is her second attack, and she's like new to your pharmacy. So you would double check. But in this case, there's no reason to indicate that she needs allopurinol. Okay, don't we avoid NSAIDs in patients with hypertension? So if her hypertension was uncontrolled, then you would avoid it. But in this case, we know from here her hypertension is well controlled, and like a steroid could increase her blood pressure too. And colchicine she may not tolerate. So in this case, the NSAID is fine, and just continue to measure her blood pressure. Okay, so question 3. 3 months later, AK returns to your pharmacy for advice on pain management. Her thumb has started to become swollen again, and the naproxen is not helping with the pain. You advise her to visit her doctor because you think she needs a change in therapy. Which of the following is an appropriate plan for AK? So should she start on allopurinol and continue her current dose of naproxen because she now has a swollen thumb? Should she start allopurinol and stop naproxen, and then maybe start colchicine instead? Should she start allopurinol, start naproxen, and start taking prednisone instead? Or should she stop taking naproxen and take prednisone instead? What do we think? Okay, so it's kind of split between A and B. It's pretty closely split. Okay, so let's go over what the answer is. So in option A, she should start allopurinol and continue her current dose of naproxen. She had a gout attack. Like, she's still in pain. She was taking the same dose of naproxen and she's still in pain. She hasn't stopped. So this won't help her because you're not increasing her pain management, right? So staying on the current dose would not help her pain. Okay. Option B, start allopurinol. So she should start allopurinol because now this is her second gout flare in the last year. So she does need urate lowering therapy at this point, right? So she definitely should start allopurinol because it's been 1 year and she's already had 2 attacks. Stop naproxen because it's not helping with the pain. Okay, and start taking colchicine for 3 to 6 months. That's a good option so far, but let's go through the other options. Start allopurinol, which we said, yeah, she does because it's her second flare in the last year. Stop naproxen, which is good because we said it's not helping her pain. And then start taking prednisone for 3 to 6 months. Okay, so that's okay. So now it's between this one and this one. We've already ruled out that it's not A. AK should stop taking naproxen, yeah, because it's not helping her, and take prednisone instead. But we've already said she needs urate lowering therapy because this is her second flare in the last year. So it can't be A and it can't be D. So now how are we going to choose between B and C? Any ideas? How do we choose? What's the right answer here? Anyone? Feel free to post. What do you think is the right answer between B and C now? We've definitely eliminated A and D. This is how you can think during the exam as well. Like eliminate options which it definitely can't be, and then usually it's down to 2 and you're like, oh, they're really close. How do you choose? Yes, so I'm getting a lot of B. Good. That's correct. So exactly. If you take for B, taking a steroid for that long, I mean, it happens. You see it a lot in therapy. It's not ideal, right? And so the colchicine would be the ideal option. Okay, so start allopurinol because she's had 2 attacks in a year. Stop naproxen, it's not helping, and start taking colchicine. The other reason why we don't want the prednisone is like right now her hypertension is well controlled, right? But if she's going to be taking prednisone for 3 to 6 months, her hypertension could really increase at that point. And I've definitely seen that in patients where their hypertension is controlled, but then they're on prednisone for so long, it becomes very high. So the correct answer is B. Okay. Okay, so some questions. If it's acute, why 3 to 6 months? Because if you think back to the gout lecture, she needs to be on pain relief while she's on urate lowering therapy so that she doesn't precipitate another gout attack, okay? Because allopurinol will start to mobilize the uric acid stores and it could cause another gout attack. So they need to be on something to bring down that pain and bring down the inflammation while they're starting allopurinol therapy. And then after 3 to 6 months, they should be okay to stop that and just be on the allopurinol. Okay, it was like that bridging that we talked about in the lecture. Does she have to start allopurinol after the attack resolved? Good question. Okay, so does she have to start allopurinol after the attack, or can she start it during the attack? Does anyone remember what we said in the lecture? So if we go back to the lecture, it could be either way. She could start it during the attack, the allopurinol, or she could wait. It depends. So you would have to warn the patient, it may worsen the pain if you start it during the attack. But as we said in the lecture, if it's somebody who maybe lives in a rural community and they can't get to the pharmacy often, or they can't get to the doctor for assessment, then she may want to start it during the attack. Or if they're very motivated to change right away, start it during. But ideally, it would be after the attack. Okay. If we had an option to give a higher dose of naproxen, could that be an option? Yeah, it could be an option. If you increase the dose of the NSAID, yeah, that could be an option. Why do you give colchicine for 3 to 6 months? So that's the bridging that we were talking about. So if somebody has a gout attack and it's their second in a year, or other examples where they would need urate lowering therapy, once they start allopurinol, the allopurinol can mobilize the uric acid stores in the body. So the uric acid gets moving in your body before you can excrete it out. And as it's moving throughout your body, you can get another gout attack. So to prevent that attack, you start allopurinol, you want to start colchicine, NSAID, or prednisone to bring down the inflammation and to prevent those attacks from happening. Because the thing is, this is where you guys can practice, this is where you can make mistakes, this is where we can discuss things so that everything's cleared up before the exam. I want everyone to leave here knowing that, okay, I'm well prepared for the exam and I've got all my questions answered. Right, question 4. So now 3 months after this, she's feeling much better. Her pain has subsided. She has not had another gout attack. And her doctor mentioned, okay, weight loss would help improve your health further. She would have less gout attacks. Her hypertension would be, she may not need medication anymore. She would feel better. So now she started to go swimming 3 times a week at her local community pool. And she's lost 7 pounds, but she's pretty unhappy still with how long it took. It took her 3 months to lose 7 pounds, and she still has a long way to go. She would like to lose more weight. Her current BMI is 26 kilograms per meter squared. She's been hearing about a drug called Ozempic. Haven't we all? Haven't we all heard this on the radio every week? So she's been hearing about Ozempic on the radio and the television, and she's asking you if you think it would help her. So what do you think? Would Ozempic help her? So with A, you could say, okay, she is an appropriate candidate for semaglutide or Ozempic, and you tell her, okay, you should ask your doctor for a prescription. Or B, she's an appropriate candidate for liraglutide, not semaglutide, and you encourage her to get a prescription from her doctor. Or C, she's an appropriate candidate for orlistat, which is also a medication for obesity, and you encourage her to get a prescription from her doctor. Or D, you counsel her on lifestyle changes, including dietary changes, to help her lose some more weight. So what do we think? Yeah, you are. The notes will be posted for this, definitely. Yeah, well done. The answer is D. So why is it D? Why is it D? Somebody tell me, why is it D? Because everybody got the right answer. It is D. But why can't she try semaglutide, liraglutide, or orlistat? What's the problem here? She's tried to lose weight. She has attempted. She's gone swimming 3 times a week. She is trying. Yes, her BMI is too low. So we have some answers. It's not less than 27. It's not less than 30. So it has to be less than 20. It has to be greater than or equal to 27. And she has complications, or it has to be greater than or equal to 30 to be able to use these drugs. Okay. So let me just write that down for you. So her BMI needs to be greater than or equal to 30 to be on these drugs, or it needs to be greater than or equal to 27, plus she must have complications related to adiposity. Adiposity-related complications. Okay, so is this clear to everyone? So her BMI is 26, and we don't really see, complications here. So she can't. She has to have more lifestyle changes. So she's going swimming, but we don't know anything about her diet. So maybe this is the time to counsel her on diet. Diet is not changed. Exactly. Okay, good. Okay, so keep this cutoff in mind, because the other thing is, I'm hearing about Ozempic everywhere, like at the pharmacy, on the radio, on TV. So this is going to be, it's a very current drug. It's something to know about. Can SGL2 after discontinued lead to rebound weight gain based on mechanism? It could lead to. There isn't that much data on it, but potentially you could get rebound. It may be hard to maintain the weight loss after you stop the drug. LM is a 35-year-old male, and he has been feeling nauseous and lethargic recently. He went to his doctor, and he was diagnosed with diabetes mellitus. His HbA1c was 7.5, and his doctor advised him to start taking metformin, 500 milligrams, once daily by mouth, and to try and lead a more active lifestyle. He has depression. It was diagnosed 2 years ago, and he has epilepsy, specifically absent seizures. He takes citalopram, 20 milligrams, and he's on ethosuximide, 750. He's allergic to peanuts. He likes playing video games at home alone. He works as a finance clerk, and his father was recently diagnosed with Parkinson's disease. So LM recently moved in to help take care of him because his Parkinson's disease is worsening. His condition is declining. Which of the following is true? LM should be started on rosuvastatin and candesartan for vascular protection. LM should be started on atorvastatin and ramipril for vascular protection. LM should be counseled on starting a high-protein diet for himself and his dad. LM should monitor for diarrhea when starting metformin. Yes, everybody got the right answer. The answer is D. Oops, I think I just deleted something. Okay, so why is it not A? Because if you think about it, it's not, so A and B are very similar, right? So why doesn't he need to be on a statin or hypertension medication? So you would be on a statin if you were 40 or older, or if you were under age 40 and you had diabetes for 15 or more years, okay? Or if you were over age 30 and you had diabetes for 15 or more years. Or if you had microvascular complications. He doesn't have any of those things. He was just diagnosed with diabetes. So he doesn't meet the 15-year mark. He's not over 40. He's 35. And he doesn't have any complications that we know of right now. Okay, he doesn't have hypertension. He doesn't have any risk factors. So we can eliminate these two. High protein diet. I mean, even if you have diabetes, you still need to have carbohydrates, right? You can't just not have carbohydrates. And his dad has Parkinson's disease, so we would not recommend a high protein diet because it could affect the absorption of his Parkinson's drugs. So it can't be C. So it's D. We know that when you start metformin, you would counsel patients on potential diarrhea as a side effect. Okay. So that's that. Everybody got that right. Question 2. LM's mood has gradually declined since his diabetes diagnosis. He's more anxious about his father's health, because remember, his father has declining health with Parkinson's disease, and he's worried about how he's going to care for him because his care needs are increasing. He's drinking alcohol more often, and he often passes out in front of his computer. His doctor decides to increase the dose of his citalopram to 40 milligrams a day. So all of the following are true except LM can expect an improvement in his mood in 4 to 6 weeks. It's unlikely that he'll benefit from CBT because he's already on the maximum dose of citalopram. Hypoglycemia and sedation can be worsened with concomitant alcohol consumption. Or LM may experience a worsening in his epilepsy if he decides to wean off alcohol. So these are the key things. So I like to underline. I think it helps me focus. So these are the key points. How do you choose the answer here? Okay, yeah. So everybody's saying B. That's correct. So if we think about it, A is true. He can experience a benefit in an improvement in his mood in 4 to 6 weeks. The physical symptoms might improve sooner, like 2 weeks, but the mood symptoms would be 4 to 6 weeks. So that's correct. And then we said it is unlikely that he'll benefit from CBT as he's already on the maximum dose of citalopram. That's not true. There's always benefit from CBT. Even if you're on the maximum dose of the drug, you can still benefit. So that's not true. C, hypoglycemia and sedation can be worsened with alcohol. That's correct. They're both CNS depressants. And if he decides to wean off the alcohol, he is at an increased risk of having more seizures. So he would need to do that under medical supervision, and the doctor would have to advise on how to do that. Okay, so the correct answer is B. So the thing I really want you to focus on for the exam is reading the question carefully. The key here was the except, okay? Don't make mistakes where you miss out on all of the above or except or all but. Read the question very carefully. Question 3. 3 months later, LM has slowly weaned himself off alcohol and he's sober. 6 months after that, his mood has significantly improved. He's undergoing talk therapy and he has a caregiver who helps look after his father 3 times a week for an hour so he can get some respite and go to the gym. His A1C has reduced to 7. Remember, it was 7.5, and his doctor is happy with his progress. One day at the gym, he falls to the ground and starts to shake. He's rushed to the hospital where he is told that he had a tonic-clonic seizure. Which of the following is true? A, the doctor should increase the dose of ethosuximide to help prevent another tonic-clonic seizure. B, the doctor should discontinue ethosuximide and prescribe lamotrigine for LM instead. C, the doctor should discontinue ethosuximide and prescribe levetiracetam for LM instead. Or D, the doctor should keep LM on ethosuximide and prescribe valproic acid too. Okay, so we have a mix of C and D. Okay, so why is it not A? The doctor should increase the dose of ethosuximide to prevent another tonic-clonic seizure because ethosuximide is not used for tonic-clonic seizures. It's not proven to be effective, okay? So it can't be A. B, nobody chose B, but let's go over it. The doctor should discontinue ethosuximide and prescribe lamotrigine. So, I mean, you can't just stop an anti-epileptic drug, right? So, in this case, the doctor is stopping it and prescribing lamotrigine. So, lamotrigine can be used for both absence and tonic-clonic seizures. So, it would help with both, but you can't just stop ethosuximide. You would have to slowly wean him off or keep him on both. So that's why it can't be B or C, because you can't just stop an anti-epileptic unless there's a really bad adverse effect or intolerance or, like we said, pregnancy. So it can't be C. In terms of D, keep him on the ethosuximide and prescribe valproic acid. Yes. So this is the answer, because he can't just stop an anti-epileptic, and valproic acid can also help with tonic-clonic seizures. So the key to this question was knowing that lamotrigine, levetiracetam, and valproic acid can all be used for tonic-clonic seizures as well as absence seizures. Okay, so when the patient has more than one type of seizure, you would want them to be on a drug that's in that first or second line therapy for both types of seizures, which is that lamotrigine, levetiracetam, and valproic acid work in absence and tonic-clonic. So those are all good options. Then the second key to knowing how to answer the question is thinking, okay, you can't just stop an anti-epileptic. There has to be a slow titration or an assessment. So in this case, the doctor is keeping him on ethosuximide, prescribing valproic acid, and then they need to decide, do we want to keep him on both, or do we want to slowly bring down the ethosuximide and keep him on valproic acid? It depends. Okay, so that's why the answer is D. Okay, so is that clear to everyone about why? Yes? Okay. And do you have any questions about like the thinking process of how I would approach this question? And if you approach it any differently, please share it with the class because maybe they like your method better. So please tell us if you have a different way of thinking about it because that could be very helpful. Okay. Like if you read questions differently or how you approach case studies, please tell us. Would the question on the exam generally be more specific as to if the drug is being discontinued abruptly or tapered off? It might be, it might not be. It's hard to say, but the key here is automatically saying, no, you can't just stop it, okay? Do you have a mnemonic for the treatment of different seizure types? No, I wish I did. I do not have a mnemonic. I'm sorry. I don't really use mnemonic. I don't know. When I studied, I never used mnemonics. But I can ask around. I'll ask and see. Okay. Okay. So that's this question. Right. So LM comes to your pharmacy a few weeks. Oh, sorry. There's a question. So we don't taper off ethosuximide. We give both for the duration. So in this case, the doctor might say, okay, taper him off the ethosuximide, but generally it would be an add-on because the ethosuximide was working all this time, right? He just had one tonic-clonic seizure. So more likely the doctor would say, the ethosuximide is working. He just had one seizure. Let's add on that. Let's add on the valproic acid. So most likely he would stay on both, okay? And it would be an add-on unless there was like a tolerability issue. Usually you would add on the second anti-epileptic drug. Because if you think about it, like, how do we do it? I don't know. They're on ethosuximide. They don't have any seizures. Then they have one seizure, and then they may go back to their baseline, or they may stay up here. But before they had the ethosuximide, they had a lot of seizures, right? So they started having absent seizures. Then the doctor gave them ethosuximide, and then they didn't have seizures for a while. Then they had this tonic-clonic seizure, and then the doctor gave them valproic acid and maintained them at this level. But they didn't go back to that high level that they were when they didn't have any drug. So maybe they need the ethosuximide and the valproic acid now to maintain them at this seizure-free level. And in most cases, that's what it would be. You would add on a second anti-epileptic. You probably wouldn't stop the first. Okay. I try to highlight main points and then cross out obvious wrong answers. This helps me if I go back to it faster. Exactly. Yeah, that's very helpful. Yeah. So you would try to highlight the main points and then cross out the wrong options. Good. Could the seizure be to hypoglycemia? It could be. Yeah, it could be due to anything. It could be dehydration at the gym. It could be anything. But in this case, the doctor has decided to add on the valproic acid. I remember we only used monotherapy if we can in most. Yeah, if you can. And in this case, like it's very dependent on the situation. So the doctor might keep him on both for a while and then slowly withdraw the ethosuximide and then see, okay, if we lower the dose of the ethosuximide, does he have a seizure or not? So the doctor might keep them on for like a few months and then lower the dose, or they might lower the dose as they increase the valproic acid dose. It kind of depends. Is it normal to have different types of seizures? You could see them, yep. How would we deprescribe seizure medications? Okay, so we're gonna go, I know you guys wanted an epilepsy, like, quick review, so we'll do that, when we do after the rheumatoid arthritis one. Okay, so don't worry. We'll go over that in more detail because there seem to be a lot of questions on this. Okay. So he comes to your pharmacy a few months later to fill a prescription for his father, DD. DD is a 78-year-old man who's had Parkinson's disease for 3 years now. He's currently taking levodopa carbidopa, 2 tablets 4 times a day, and rasagiline 1 milligram once daily. Recently, he noticed that his father's medication stopped working an hour and a half before his next dose was due. This left his father feeling very stiff and uncomfortable. His doctor prescribed him entacapone 200 milligrams. Which of the following is true? So, is it A, DD is experiencing wearing off and entacapone will help his symptoms? This prescription can be dispensed. No other changes are required. B, he's experiencing on-period freezing and entacapone will help his symptoms. This prescription can be dispensed. No other changes are required. So the difference here is here we're saying it's wearing off. Here we're saying on period freezing. C, DD is no longer needs rasagiline as entacapone will improve his symptoms. So they're saying, okay, just stop the rasagiline. And D, DD is experiencing wearing off. And entacapone will help his symptoms. His dose of levodopa should be therefore reduced. Great, everyone got it right. The answer is D. We said that at the beginning. If you're adding it on, you need to reduce by 20 to 30%. Okay, if you're adding on the COMT. Okay, so well done, everyone. Good.